Welcome, everyone. For those of you who don't know me, I am Christine Williams, and I am the Executive Vice President at OICR, but also head of our Implementation Science Program. And I co-lead that with...
I'm Harriet Feilader, and yes, I co-lead this with Christine. And together we are trying to launch this implementation science program. And so this workshop is sort of a flagship for us to get that all going.
Yeah.
Hi, I'm the project manager for implementation science, working with Christine and Harriet, helping organize events kind of like this. It's a workshop today, but we're excited to present.
So you're really here to hear our guest speaker, who's Robin Urquhart. So we'll not spend too much time on the intro, but I just wanted to say a few comments. Welcome, especially. We've had great participation in this. It's always awkward having a webinar. I know it's difficult because you can see us, but we can't see you. But we do that for security reasons. But for just so you know, the chat is enabled, so you can put comments in the chat if you like. We will try to follow along. But more importantly, we will have Slido open, and we'll get to that in a moment so that you can ask questions at the end of the talk. And I see somebody raise their hand, but we won't be able to call on you because you don't have a login, so you'll have to type a question. Okay, next slide. Okay, so by way of introduction, I wondered for how many people this is a familiar scenario. So you have researchers on one saying, this is a significant finding that will change patient care. And obviously that is ultimately what we're all trying to do with cancer research. But then you have equal enthusiasm, but additional questions on the other side of this from health policy people, health system leaders, people who may be clinicians or in charge of implementing a change. And they are going to ask questions like, what is the evidence that this is significant? Is this a problem we need to solve? What will it cost? What will need to change in order to implement this? Will it work? And for whom is it going to work? So this is the gap that we likely are all familiar with between knowledge, new knowledge, and action, what we do with it. Next slide. So this is, in recognition of this challenge, we have earmarked a new program or started a new program at OICR in implementation science. And implementation science is really meant to enable all of the research happening at OICR, but indeed across the province. Our research is focused in three areas: in clinical translation, which is really about preclinical and clinical research and clinical trials; therapeutic innovation, which is about developing novel therapeutics, either biologics or drugs; and then adaptive oncology, which is our way of talking about the evolution of cancer and the need to be precise in our treatment of it at different stages of evolution. So we have three different enabling functions at OICR to support all of this work, both building talent and providing collaborative research resources to the community. But now we also have implementation science. And at OICR, we talk about implementation science as being an important way to promote the uptake of evidence-based practice and research into regular use by policymakers and healthcare providers. Next slide. So the way what we're doing in terms of implementation science and the goals for the program, we really have four different ways we're tackling this. One is by funding evidence gaps, and we're going to come back to that and probably focus most of our conversation later after Robin's talk on that. But we have a grant program called Innovation to Implementation Grants that funds implementation science work. But we're also working by trying to influence public policy. In our case in Ontario, our partners in this are really Ontario Health and the Ministry of Health, but other stakeholders as well. Trying to facilitate the adoption of an innovation pathway, so a more structured way of systematically evaluating and implementing more new research into cancer care. In some cases, we're bridging system gaps, so identifying particular gaps and trying to fund programs that will address them. And the example here is an implementation lab that we've newly started to do biomarker test standardization in order to support its adoption across clinical labs in the province. And then the last thing, of course, is promoting knowledge translation and synthesizing, disseminating, exchanging, applying anything to do with knowledge related to our funded research, but research generally to broader audiences in order to influence decision-making. Slide. Okay, so just before we get to Robin, a technical housekeeping thing. So we will listen to Robin first, and I'll introduce her in a moment, but we would really welcome you to submit questions for the discussion period via Slido. And this is the QR code. You'll see it on the next slide as well, but if you go to that location, you'll find Slido. For those of you who are not familiar with Slido, you can type in a question, and you can also look at other people's questions and vote them up or down. So if someone's asked a question that you wonder about as well, you can vote it up so that, and we'll answer those questions in priority at the end. Slide. Okay, so the real star of the show today is Dr. Robin Urquhart. And Robin is here to teach us a little bit more about the basics of implementation science. And this is a gap that we've identified through doing 2 rounds of the I2I grants, that there's a lot of interest and enthusiasm in doing implementation science work, but not as much understanding or knowledge about the methodology of it. So Robin was part of our review panel, in fact, co-chaired it, and has very graciously offered to help us with today's seminar and really an educational webinar for all of us. So Robin, if you don't know her, is a very esteemed professor at Dalhousie University in Halifax. She's the Canadian Cancer Society Chair in Population Health Research, and she is a real implementation scientist, doing a lot of groundbreaking work, mostly in cancer, elevating cancer care standards and outcomes, and using really innovative research and implementation approaches. Robin is also a lovely person and someone I really like, and also very generous with her time. She sits on a lot of advisory boards, and including helping out OICR today. So I just really wanted to thank Robin, and look forward to hearing what she has to teach us, and we'll turn it over to Robin.
Hey, thank you, Christine. I believe I can just share my slides.
Yeah,
now.
so
okay. I will say as I start to, okay.
Stop share here.
Yeah.
And let's see. Okay, so do you see the slides okay? Perfect. Okay, thank you for that. I will say when I see the when I see sort of the Canadian Cancer Society chair and so on written underneath my name, or when someone mentions it, I always think about my kids who still can't quite understand what a chair means. When I first got it, I was asked whether that meant the Canadian Cancer Society actually sent a chair to my office that I sit in. So it's yeah, that's just a little thing that I think about whenever I see it. So before we start today, I do want to give a land acknowledgement in terms of, oh, I just messed something up. And I don't know what I messed up.
All right, we can see your slides. It's okay.
Oh, I couldn't see them. Okay. Okay.
You're
I
on
don't know
land
what...
acknowledgement.
Yeah.
Perfect. Okay. My slides went away. And so I just wanted to give a land acknowledgement in terms of where I sit today and where I live and I work, which is on the ancestral, unceded, and unsurrendered territory of the Mi'kmaq people. And, you know, here in Mi'kma'ki and at Dalhousie, all of us, we believe all of us have a responsibility to continuously educate ourselves and work in solidarity with Indigenous communities. So we are all treaty people. We also recognize here, and I recognize, the histories, contributions, and legacies of the African Nova Scotian people who have lived in Mi'kma'ki for over 400 years. So today, I'm going to sort of talk about what implementation science is, and a little bit about why we should care about it. I want to talk about 3 sort of methodological parts of implementation science. So the use of theory, and hopefully it's not so scary after I talk about that. Implementation outcomes and what we mean, what us implementation scientists mean when we talk about these outcomes, and then some sort of study designs in implementation science. I sort of want to end by giving a bit of a published example of what I think is a really good lesson in implementation. yeah, it just an understanding sort of what happens in the real world behind the scenes when we talk about implementation, and then just a few key messages. So I'm going to start with this quote. This is a quote I got a number of years ago now, probably actually 12 years ago, in some work I was doing in pathology. But this is from a community pathologist. And so I was really looking at the introduction and use of sort of new criteria in terms of subtyping, which is no longer relevant today. This was 12 years ago. Or you know, with where we are today. But essentially this person said, new discoveries, new. We already have so much that is discovered, and don't translate that into clinical practice. And practice basically is still based on the criteria established 30, 40, 50 years ago, and we have not translated a single thing. So I like that quote because it illustrates sort of two things that I think are really important. And sort of that I've spent a lot of time sort of studying, you know, how to get research findings into practice. So that actual process, like how does that happen and how can we make sure that that happens? And then how to speed up the rate of this process. You know, we don't want it to take 30, 40, or 50 years to get new research into practice. So implementation science, the actual definition of it, if you were to Google it, you should get something very similar to this. It's scientific inquiry, so it is an actual field, a growing field of science that really looks at how evidence-based practices, interventions, policies actually move into routine practice, routine healthcare. Many of us in this world are really interested in and study sort of the determinants of adopting research into practice or into policy, of implementing that research, that process of implementation, and then of scale up, sustainability, and more de-adoption. So, you know, there are many things in our health system, there are many things that we do that maybe we don't even think about anymore, but probably don't provide a whole lot of value to patients or even to our health system. So how do we take those things out? And of course, we test strategies to more effectively and efficiently do these things. So there are better words than that, though, I think. So this is sort of a implementation science simplified by Jeff Curran out of the US, published a few years ago in Implementation Science Communications. But essentially, this is it. So the intervention, the practice, the innovation, whatever it is that you want people to do, what you want people to use, is the thing. So think of it as the thing, right? Effectiveness research is going to look at whether the thing works. Does X work or not? Implementation research actually looks at how best to help people or places actually do the thing. So that's implementation science. That's where we sit. You know, how do we help people actually do this? When you hear the term implementation strategies, really that's just the stuff we do to try to help people do the thing. So the stuff we do, the education we provide, right? Maybe the incentives we provide within the system. Maybe there are financial incentives. Maybe the audit and feedback that we do, other quality improvement sort of techniques that we use. So all that stuff that we do to try and help people do, the thing, or to sort of use that intervention. And a lot of implementation outcomes actually are really around, I'm going to touch on this, how much and how well people do the thing. So it's not just about whether the thing improves patient outcomes, whether the thing, it reduces the cost of care, I don't know, whatever it is. It's also about how much and how well people actually do the thing. So I'm going to refer to the thing throughout this talk. So I thought I'd start here a little bit, and I'm sure everyone has seen this. This comes from CIHR years and years and years ago now. But essentially, it was this depiction of these two, what were termed sort of valleys of death across the whole research to practice continuum. And so many other people have sort of conceptualized this. I've seen things where there are 6 valleys and that sort of thing. But, I really like this for simplified purposes. And so you have this valley 1 between, basic discovery research and sort of clinical trials, clinical science, and so on. And then you have this second valley between sort of clinical science and trials, epidemiology and so on, into sort of this gap, which is what Christine was referring to earlier, between this sort of clinical science and what actually happens in healthcare. So just to give you some context here. So in this valley, most people probably know, most things that get sort of studied in the lab never actually get tested in humans. That's okay. I have no idea what we would expect, how much we would expect to get tested in humans, but it's okay, because this is discovery work. Like, this is where we make breakthroughs and we understand what's going on, at the cellular level and so on. And not everything is going to pan out, right? And not everything's going to be relevant eventually, or need to be tested. But I think something also interesting is that for every 5,000 to 10,000 compounds tested, only 5 actually do make it to clinical trials, and only 1 is ever approved by the FDA. Again, I'm not sure what that number should be. I actually have no idea, but that just gives you a sense of that gap. And then we have this second valley here. And this is just really, again, the failure to sort of translate research, what we know, into patient care, right? So we've got decades of research to actually show us that 30 to 45% of care is really inconsistent with scientific evidence, or with what we would consider best practice, in whatever field that is, or in whatever sort of clinical area that is. And then 20% or so to a quarter of care is unnecessary or potentially harmful. So we often call this low value care today. Low value care. And so we've seen these numbers for a couple of decades in big studies now in Europe, in the US, and in Canada. And I can say that when I do my own research here in Canada in the cancer system, and in cancer care, and if I'm looking at adherence to practice guidelines, as an example, adherence to treatment guidelines, whatever that is, I'm also finding, ranges in numbers in the same range, right? And so I think it's been fairly consistent over time. And then the other part about this valley is that, you often see this number takes about 17 years for clinical research to make its way into day-to-day clinical practice. So there was a big study done. It was published in 2001, I think. It looked at everything from, flu shots to sort of breast cancer screening, colorectal cancer screening. It looked at beta blockers. Like, it just looked at, 10 to 12 different sort of innovations. And then it tracked how long it took from the publication of the clinical trial showing effectiveness to actually making its way about 50% of the time in clinical care. And so the average was 17 years. So that's where you get that 17 years from. I would hope today it's shorter than that. It'd be interesting to study that again. So in terms of implementation science, this is one of the big studies that showed this sort of gap in care. And I'm just bringing this up as one example, but this really did spur this whole idea of, okay, we have a problem, we have a gap, we have to figure out what we're going to do with that. And so this was a study in the New England Journal in 2003, 20 years ago, over 20 years ago now, but the quality of healthcare delivered to adults in the US. And it really looked at, again, recommended care in terms of acute care, in terms of chronic care, in terms of preventative care, and so on. And it found that there was a lot of, as I'm sure most people aren't surprised, a lot of variation in terms of recommended care. So I just put this together in terms of some of the things that they were looking at. But the whole point here, and this is 20 years ago, but the whole point is there's huge variation, right, in terms of recommended care or adherence to scientific evidence when it comes to some conditions like cataract, and then very low when it comes to some other conditions or issues such as hip fracture or alcohol dependence. So huge range here. What are some of the barriers to actually putting that evidence into practice? I'm not going to go through these. My only point here is that they exist at a lot of different levels of the system. So they exist in terms of providers and providers' knowledge, skills, motivation, and so on. They exist at the level of the patient, right? They exist at the level of the sort of social context. So, relationships in the system and opinions of colleagues and so on. Certainly in terms of the organizational context and the culture at the organization, leadership, capacity, resources. And certainly in terms of how healthcare is regulated, funded, and I'd say the small p and big P politics of it. So there's many levels or many layers of sort of potential barriers to actually using research findings to benefit patient care. So why am I saying all this, and why is this all important? I think at the end of the day, this is how I see it, to be quite honest. We know from the literature that implementation is a known determinant of effectiveness. So this is how I would put this. You can have the most effective intervention in the world, the most effective intervention. Let's talk about vaccines for measles. That's what they are. No. And if it's not implemented successfully or effectively or consistently, you are not going to get your desired outcome. And so this is where I come at. This is sort of my thinking around implementation science and why I've been sort of active in the field and have done a lot of time sort of studying in this area, is that, we can again prove trial after trial that some intervention is effective. But if people don't actually use it, patients aren't going to benefit, right? And the health system is not going to benefit. So this was a quote from a colleague in the US who's an implementation scientist, and I like the way he put this. It doesn't matter how good the innovation is. It doesn't matter how much has been invested. If we don't have the implementation savvy, we're going to get the crummy outcomes that we have seen decade after decade. So, the latest research shows us that we really should do something with all this research. Okay, so again, implementation science is this growing field of science that really is just looking at and investigating how we get people to do the thing. I want to talk now about theories and research methods and implementation outcomes, so sort of the meat of the talk. So there's a range of theories that underpin implementation science. I know that's my experience, when people come to me and we start to sort of talk about an implementation science project and maybe putting in a grant application, this is probably the scariest part for people, because they start to delve into the literature, and probably literature they're not that familiar with. And all of a sudden they see hundreds of theories out there. And, the most common question I get is, well, what's the best theory to use? And people probably don't like my response, because it's like, well, it depends on what it is you're going to do, and it depends on your context. So I want to talk a little about theories, then I'll talk about some research methods, and we'll go from there. So this is a very evolving science, but I wanted to point this out, and this gets into why we use theory today. So 12 years ago, Jeremy Grimshaw, who's in Ottawa, published a paper in implementation science. And at that point, so 12 years ago when he published this, there were already over 7,000 trials and quasi-experimental studies on different strategies to put the thing into practice. So there were already thousands of studies and thousands of trials looking at different strategies. And again, strategies could be audit and feedback, could be continuing education, continuing professional development, could be patient-mediated strategies, all kinds of different things. But essentially what this review, it was a review paper, what this review found was that there was really small and kind of inconsistent impacts of a lot of these strategies on clinical behavior, so on changing providers' behavior, and also on patient outcomes. And in the end, sort of the conclusion, I would say, it worded differently in the paper, but the conclusion was, so these strategies work some of the time in some situations, but not at other time in seemingly similar situations, and we don't know why. And so this is sort of kind of spurred the movement of using theory as really a best practice in implementation science. Because theory just allows us to it gives us another tool in our toolbox to help us understand what's going on in any particular situation. It helps us frame a situation. It helps us understand all the potential maybe influences on a situation, and maybe the mechanisms by which people change behavior or don't change behavior, or decide to change behavior, and so on. And so coming out of this, it was the state of the science was more like, we would choose these strategies, you know, thinking it just seems like a good idea, right? But not really having it supported sort of by theory or support or working through, you know, what it is we expect the barriers are and what we expect to happen with this strategy and why this strategy might be better than another strategy. So I'm going to talk about theories for a minute. And I like this quote. Theories are like toothbrushes. Everyone has their own and nobody wants to use anyone else's. I feel like this from theories. When I was doing my PhD, it was an implementation science PhD. And my committee at the time was pushing me to develop a theory. Like that should be the output of my PhD, is a theory, is a theory. And I resisted it because of this. I didn't think we needed more theory. I thought we just needed to sort of improve on the ones that we already had and use those. And so there's a great paper out there, although I hesitate to sort of send it off sometimes to sort of new people to the field. But it's a paper and it's called Making Sense of Implementation Theories, Models, and Frameworks. It is very dense, but it is also, I think, very useful. So what this paper does is it organizes all the different theories in implementation science and says they really have three different aims. There's really only three aims here. There are process theories, and I'm going to show you an example of one, where really it just helps describe the process of translating research into practice. So if you're taking on a project and you just want a framework again, you just want a structure to help you, okay, these are the steps I have to go through. These are the steps, you know, based on the literature and so on, that I have to go through or that our team should go through to translate research into practice. You know, these sorts of theories or models are very helpful. The other group of theories and models are called determinants frameworks. And that's just trying to understand what actually influences implementation. So what actually influences whether people do the thing or they don't do the thing. And so I'll give you an example of that, of one of those. And then the other are evaluation frameworks. Again, it's just a structure to help you think through, okay, yes, I should be evaluating this, I should be evaluating this, I should be evaluating this. So the first theory that I'm going to put up here is a process theory. It's the knowledge to action process. Ian Graham out of Ottawa, really it's sort of his and his colleagues' work. And again, this just describes the process of translating research into action. It's useful, I think, often when you do put together a grant application and you can actually say, you know, we are following these steps, right? That are, and from this well-established framework to improve our chances of being able to actually sort of inform change. So this is not a complicated model. If you haven't seen it before or have only seen it briefly, the inside here is what's called the knowledge creation funnel. It essentially is just like, you know, we have all these primary studies and they may say various different things on whatever the clinical issue is. And then, you know, we synthesize those. So one method in implementation science is like knowledge syntheses. So that might be systematic reviews, for example. So we synthesize the knowledge. And in the end, as we synthesize it, you know, we tailor it more. And we often come up with products or tools to try and impact change or try to impact sort of the translation of research into practice. And one very simple, easily sort of understood tool would be a clinical practice guideline. And then outside you have the action cycle here. And really that's just, you know, I'm not going to go through all of this in any depth at all, but I mean, you identify the problem, you go out, you search in the knowledge, what's out there, what's published, however you sort of get your knowledge. And then you sort of, you know, figure out what the thing is, like what thing might actually, you know, solve this sort of clinical problem. And then the action process is really, you know, adapting that knowledge to the local context, assessing the barriers to actually using that knowledge, and then maybe selecting and developing strategies to put that knowledge into practice. And then, of course, there's the monitoring, the evaluation, and so on. So this is just simply a process model that takes you through steps to do, you know, in sort of an implementation project. So now I'll talk about a determinants framework. And again, a determinants framework simply tries to explain the influences on why people do what they do or they don't do, or why they do the thing or they don't do the thing. There's a number of them out there. There's a lot out there, actually. One of the most commonly used ones would be the Consolidated Framework for Implementation Research, CFIR. Which I'll put up here. There are others, so you may have heard of the Theoretical Domains Framework, so TDF, and the Behavior Change Wheel. So that's another sort of determinants framework that's out there that can help you in this work. I put this up because CFIR has a really nice website. Well, I don't know. I want nice as in a lot of resources on their website to really help guide you in your work. So they, you can see here they have interview guide tools and observation templates, code book templates if you're doing qualitative data collection and so on. But essentially what it does is it organizes, it has 5 domains in terms of different domains that influence implementation. What it did is it consolidated a whole lot of theories that came before it, a whole lot of frameworks that came before it. And then it sort of laid out, a number of, I think it's 32 different constructs, but 32 different factors that are known to influence implementation. And so this is the framework. It is simply a framework. And then it's actually created a whole lot of different tools and resources for you to be able to use that framework in your research. And so when I use this as one example, I will use this framework. Maybe I am looking at the implementation of, a new pathway for follow-up care after cancer treatment. And so what I would do early on in that work is I would use this framework, which I use quite a lot. And then I would go out and I would probably collect qualitative data. I've done it through surveys as well, where I would understand, okay, what are the key barriers using this framework? What are the key barriers to actually implementing that new pathway into care? What are the key facilitators we have, let's say here in Nova Scotia, to actually implementing that new pathway into care? And then I would use the barriers and facilitators information that I got. I'd hone in on the key ones, and then I'd select strategies that actually target those barriers and facilitators. So this is why I like CFIR, because there is another complementary set of tools that essentially is like a compilation of implementation strategies. So the stuff we do to try and get you to, use that intervention. And so it's a compilation of implementation strategies, and these teams have worked together, and I can certainly send this out through Christine and through OICR, sort of the resources. But I mean, if you Google, you'll find it. But they've worked together. So they actually have a mapping of sort of, if you find these key barriers, these are the implementation strategies most likely to work. If you find these key facilitators, these are the most, the implementation strategies you might want to take on to leverage, or you might want to put into place to leverage those facilitators. So this has been at least 15 years, well, based on more work, but these teams have been working on this for at least 15 years, and there's really good resources out there. Again, it's to understand your own context, right? It's to understand what are the main things I need to be thinking about if I'm putting this intervention into practice, this pathway. Let's say I'm implementing this pathway. And then when I understand those key sort of things, what are the strategies that I might use to try and overcome those, those barriers, those challenges. Okay, here you go. I put that in there. Look at that. So the CFIR guide and then choosing strategies. So again, this whole idea of tailoring your strategies to the actual, your actual context, your actual setting. And then the next set of frameworks, models, theories are really evaluation theories or evaluation frameworks. I would say the most frequently used is called RE-AIM. So many of you may have heard of RE-AIM at some point. RE-AIM stands for reach, efficacy, or I think effectiveness, adoption, implementation, and maintenance, or sort of sustainability. And essentially, again, I use this all the time to develop my evaluation for a project, but it just allows you to think through, and these are just sample questions, but it allows you to think through, okay, I really need to look at reach. So who's actually using this thing? How representative are they of, the people I want to use this thing? And so I can monitor that in an ongoing basis. Effectiveness. So that really is sort of, more traditional effectiveness outcomes. And then sort of, adoption, which here is at the setting level. So what percentage of primary care practices, I don't know, are using this pathway, and so on. So I won't get into this, but it is actually a really nice framework. And I'm happy to work with anyone on sort of thinking through things or even giving more resources. It's a really nice framework just to set up your evaluation. Okay, so implementation outcomes. So one of the things that's interesting to me is, as a reviewer, and I don't mean at OICR, I mean just broadly when I review implementation science projects, is people may do a barriers and facilitators assessment and understand, have a better understanding of how to get an intervention into practice, maybe a new test, a new technology or something into practice. And then, they study only the effectiveness on patients, let's say, or maybe on the health system. Maybe there's a cost measure or something in terms of the health system cost. And they don't include implementation outcomes. And so when I put together, just because I'm in this field, when I put together a project, I will have my effectiveness outcomes, but I'll also study the implementation, right? Because again, it goes back to that whole idea that you need, an effective intervention and a successful implementation if you're actually going to get the outcome that you want. So these are the things, implementation outcomes are often, the things that you need in place if you're actually going to achieve the desired outcome. So you need people to use it. I mean, that's the simplest way to put it. And so an implementation outcome would be, are people actually using this, whatever it is? I mean, I've done a lot of work over the years in advanced care planning and trying to get people, to use advanced care planning, I guess, in the context of, a life-limiting condition. And so in terms of that work, I will, devise strategies to put advanced care planning, to have advanced care planning being used and a part of that clinical conversation and a part of a family patient, conversation. And I'll study the impact of advanced care planning on patients or families, let's say, but I'll also study, whether people use it and how they use it and what parts of an advanced care plan maybe, or that process were most beneficial to people and so on. So those are all implementation outcomes. How will you know if the intervention was ineffective in a new setting if you don't study implementation outcomes? How will you know if the thing was ineffective or it just simply wasn't deployed appropriately? You're not going to know that. So here are sort of a framework from, again, 13 years ago, but those of us in implementation science, this is sort of, what we think about when we think about implementation outcomes, things like acceptability. So is the thing acceptable to providers? Is it acceptable to patients? Adoption, again, sort of, are people actually using the thing? Appropriateness, there's a number of different ways that you can sort of look at that. Sometimes satisfaction is measured. You'll see that in client outcomes as well, but just satisfaction with sort of the thing early on. Cost of implementation, so not just cost of the thing, but cost of implementation. Feasibility, I do a lot of feasibility work when I'm trying to put new things into the system to see how feasible it is. Fidelity is, is the thing being used as planned? Penetration, how integrated is it? And then sustainability. So there's a lot of work been done around these implementation outcomes and a lot of sort of thinking, and there's a lot of guidance in the literature, actually. Study designs, there's nothing really big here. It's really like any other field in what I'll call applied health research. There's lots of trials in this area. There's lots of quasi-experimental studies. I've done a lot of time series analyses. right from mixed methods to qualitative knowledge synthesis, realist evaluation. I would say a lot of studies are mixed methods. So even if there's a trial, there's qualitative work also to sort of understand the implementation. And I would say by nature of this, it's a very highly interdisciplinary field. The teams that I've been involved with, not just ones that I've led, but been involved with, really do bring people in from different disciplines. So we get different perspectives on the problem. I do want to bring this up. So there more and more people are doing what we call hybrid designs. It's essentially just evaluating the impact of these interventions from an effectiveness standpoint, but also we're evaluating the implementation at the same time. This helps avoid type 3 error, or in other words, making sure you're asking the right questions and you're not thinking something worked or didn't based on, effectiveness data only. And I think it provides information to, inform implementation after a study. So if the intervention is shown beneficial, then you want to understand how to implement it, right? This is just an example. It's all outlined in, again, Jeff Curran's work in Medical Care in 2012. But essentially, there's loosely 3 types of hybrid designs. And in the first design, which is probably the most common, I think, is where the primary aim really is still to determine the effectiveness of the intervention. Does it work? Does it work in this setting? And the second aim is to understand the context for implementation. This, and you can read here the different types. So this type 2 would be sort of primary aims or co-primary aims, determine effectiveness and sort of the feasibility or the utility of an implementation strategy. I would say type 1 is the most common. And so just as an example, a colleague of mine at Princess Margaret, Dr. Jackie Bender, is just finishing up a hybrid type 1 effectiveness implementation trial, looking at the effectiveness of virtual web-based peer navigation for prostate cancer. And so in that trial, she's certainly studying the effectiveness on patient outcomes. So the effectiveness of, peer-led web-based navigation on patient outcomes, but also doing a whole lot of work to understand implementation outcomes and to understand the context for implementation. So looking at the experience of patients and navigators, looking at fidelity to the intervention, looking at barriers and facilitators to actually sort of implementing it in oncology settings. So there's a whole lot of additional work going on there. Okay. Rarely is real life as rational and structured as implementation science often assumes it to be. So I've done a lot of implementation science projects that have been set up, I would say, like very robustly. They've been theory backed. We've done pilot work. We've had implementation outcomes. We've developed our intervention in a co-design way. So, if you had your checklist, everything was done right, and they didn't work. And so, and they didn't work. And thankfully, we had sort of a process evaluation built in. So we could sort of get at why they didn't work. But the reality is oftentimes they didn't work because real life is very messy, and it's not as structured and rational as we like to think. So I just want to talk about one article here, and I feel like I don't have a sense of time. So please somebody step in or send me a note if I'm going too long. I don't have a clock here. So basically, this was a publication that was, in the New England Journal in 2006, an intervention to decrease catheter-related bloodstream infections in the ICU. So you can imagine it got into the New England Journal. It was highly effective. Unfortunately, null trials rarely get into the New England Journal, even though they're very important. And so essentially at the end of the day, the conclusion is an evidence-based intervention resulted in a large and sustained reduction up to 66% in rates of catheter-related bloodstream infection that was maintained throughout the 18-month study period. And this happened in 108 ICUs in Michigan. So it was an ICU-based intervention. What was the intervention? It was a checklist. So these researchers implemented a checklist, again, 108 ICUs in Michigan, that really sort of emphasized, I guess, evidence-based processes of care, again, to prevent bloodstream infections. They found a dramatic reduction, in infections in over 100 ICUs. They saved a tremendous amount of money. They were able to estimate how many lives were saved. Michigan as a whole, infection rates fell so low that its average ICU outperformed 90% of ICUs nationwide, and the successes were sustained. There's been a bunch of articles that have been published since, actually looking at the sustainment. So this is really awesome, right? And then the implementation science person in me says, there's no way a checklist on its own could have done this. Like, whoa, can you imagine? If so, we'd all be using checklists all the time in every aspect of our lives. And so there's another person who's a social scientist who saw this paper also, Mary Dixon Woods, and contacted the team and said, whoa, what happened here? Like, congratulations, right? But like, really, how did this work? And why did it work? Because, we don't see the same benefits elsewhere. So this team then went on and sort of tried to explaining Michigan, right? But really tried to understand, okay, why did this work so well? What happened behind the scenes for this to work so well? And I think this is just a really good example of implementation in the real world. So the outcomes were completely accurate from the New England Journal paper, absolutely. But the story was grossly oversimplified. And you can imagine, a New England Journal paper needs to be very sort of concise and, very, very to the point, I guess. But this is just some of the strategies. What they found is there was all kinds of strategies at the different ICUs to get people to use this checklist. So there was very engaged senior leadership, and they worked very hard to engage senior leadership at each of the ICUs that took part in this study. They supported physician and nurse champions. They did a lot of safety and improvement training. All of the staff in these ICUs had access to expert faculty. They did audit and feedback. So they measured what staff were doing and they regularly fed that back to staff. They had opportunities to get regular feedback from staff to change their strategies or to add strategies or to change the checklists and so on. Some of their strategies in some of the ICUs to change ICU culture were that nurses were allowed to stop procedures. So not only physicians, but nurses were, if they saw something wasn't happening quite right. And they certainly had the ability to adapt their intervention for local ICUs. And so in a subsequent paper in The Lancet, there was also this quote around this study. There was not a uniform instrument, but rather more than 100 versions. Each ICU, informed by evidence and a prototype, was encouraged to develop their own checklist to fit their unique barriers and culture. So I think this is, I love this because I think it demonstrates in the real world, we don't have one intervention that works everywhere. And a really big part of sort of implementation and implementation science is understanding how will this thing work in this setting and how can we adapt it to work in this setting, and what strategies do we need? Like, what do we need to do to get people to use it? And then we do those strategies or we put those into place. And I don't know about anyone else, but I think that if the authors of that original paper in 2006 wrote this up for the New England Journal and said it wasn't a checklist, it was more than 100 checklists, it probably wouldn't have gotten published in the New England Journal. I just wanted to point this out. It worked so well that the UK wanted to bring this program over to the UK. And so they called it Match in Michigan. And so they took this sort of checklist, they sort of, wanted to take what happened in Michigan, drop it into the UK and get the same results. Well, the same author, Mary Dixon Woods, so it didn't work in the UK. Spoiler, didn't work. Mary Dixon Woods studied it again to see, okay, so why didn't it work here if it works so well in Michigan? And you can see some of the reasons here. And I think lots of people have experienced this over time, but in the UK, it was viewed as a very top-down driven by government approach. people were given little training. There was little understanding of what they had to do for sort of the non-technical elements of sort of the program itself. There was a long history of sort of under-resourced QI initiatives, which, lots of people had change fatigue, but, lots of people were just apathetic about it, and some were resentful, right? Because, they'd been promised things before and it never happened. And, they found that the extent of consensus and coalition among senior medical and nursing staff was the most important influence. So again, I really like this because it shows you just can't take something. And I do a lot of this. I look at what's working elsewhere, what's working in maybe some European countries or in Australia, and then try to bring that to Canada. But do a lot of adaptation, a lot of work understanding how this will work here and what strategies we need in place for it to work here, sort of recognizing that I just can't take, something done in a different context in a different country and plop it down in Nova Scotia. So, checklist studies, there's been a lot of conflicting results, but I'd remind everyone that checklists are reminders, and they might address a technical problem, but not all of the other stuff that's going on in our health system. Okay, I'm just about done. I've got a couple slides here sort of around making impact, and I put these up because I'm guessing that most of the audience are researchers like me, and we really want to make an impact with our work. I don't think you would be at this workshop if you didn't. And so I think that, research is a really key ingredient of impact. Obviously, you need effective interventions. You need things that have been shown and demonstrated effective and demonstrated beneficial to make impact. But I think there's a lot more that I've learned over the years doing this work. One of them is that, research is global. We try to create generalizable knowledge and everybody has access, or globally people have access to that knowledge. And I think often a lot of our problems are global. Oh my goodness, I just came back from Australia. We were talking about primary care and cancer sort of was the focus of the meetings. But the primary care problem and capacity and so on is everywhere, right? But solutions are usually local. And so let me just bring up a final example. This is what we would call the government wharf in the community that I grew up with in rural Newfoundland. So I would have seen this, basically this picture or this sort of view every single day of my life growing up, a very rural community. And so if I think about Newfoundland, not a lot of people live here or there. So about 500,000, just over. A lot of people live in very rural areas. So about 40%, according to the latest census, of Newfoundland and Labradorians live rurally. That's greater than 2 times the national average. Almost a quarter are 65 years of age or older. And from the latest census, which was a few years ago now, 8.2% of adults live in poverty. That actually dropped substantially from the previous census, but it was sort of some government aid programs and so on thought to be responsible for that. But nonetheless, some data from last year showed that most adults in Newfoundland and Labrador are less than $200 away from insolvency. So it's not a very wealthy place. Here's a picture I took of Toronto a number of years ago, coming back in the summer from Toronto Island, which is one of our favorite places to go. A lot of people live in Toronto, which is great. I love Toronto, but latest count, I think just in Toronto itself, is over 3 million. 16% are 65 years of age or older, so a little bit younger in the city than, let's say, in Newfoundland. 52% identify as visible minorities, very different context also than Newfoundland. And the latest census shows that 10% of adults live in poverty, which is higher than the national rate and higher than what I had showed you in Newfoundland. So why do I bring this up? So my hunch is that if you were looking at that many of our problems are common. So I think that if you were looking at a health system in rural Newfoundland and in downtown Toronto, you would see a lot of capacity issues. I think you'd see a lot of burnout issues. If you were looking at your population, you may be working with a population that does have sort of, high levels of poverty, particularly in certain areas. There may very well be issues around cancer diagnosis and equitable access to care and all of that. So I think we could pick out, for sure there's unique issues, but I think we could pick out a lot of common problems. But I think the solutions in rural Newfoundland and sort of, urban or downtown Toronto are going to look very, very different. And so why do I bring that up? Well, one of the things that I do in my implementation, wearing my implementation science hat, is really try to understand those contexts, right? And so implementation science has really grown with the knowledge we have and the evidence base and the resources and so on that we have now. And it really is, an area or a field where we have these well-established and sort of even, theoretical underpinnings, but well-established techniques and approaches to really develop or identify things that might work in that setting. So to understand the setting, to identify things that might work, to really understand the stuff we can do better to put those things into practice, and then of course to test them and evaluate them and report on them so others can learn what we do. And so this is sort of, I think, a really important, I don't want to say use of implementation science, but I mean, it's sort of how I think about implementation science, right? I take the tools and the approaches and the methods to really understand locally, how you come up with solutions, and then how you put them into practice and how you test them. So to recap, what implementation science is not, it's not discovery research, it's just different, right? I wouldn't say it's biomarker or test development, but it is trying to get effective biomarkers now into the lab or into patient care. I've done algorithm development. I wouldn't consider it algorithm development or validation, but it certainly is, okay, so how do we take that algorithm now that looks really promising and test it in the real world and also test the implementation of it in the real world? It's not efficacy research, not really effectiveness research, but again, I think a lot of research now is looking at both the effectiveness and the implementation at the same time, and I really like that approach. What it is, certainly highly interdisciplinary, but really it's just research that helps people and places do the things that work. I mean, that's the easiest way to put it. So this is my last slide. These are some questions to ask, or these are questions I ask myself anyway, when I'm starting out in terms of implementation science, whether it's more like of a quality improvement project that I'm working on with the health system, or whether it is like a research project, right? So, okay, so you've got a thing you want to implement. So how will that thing complement existing technology practices or policies? The flip side of that is how will the thing sort of disrupt, right, existing technology practices and policies? So having a conversation with your team and maybe others around that. I think this is number 2 is important. What needs to change and for whom? And so the second point there is something I always ask people. So who will be impacted by the thing and who can impact the thing? So you want those people on board and you'll want to understand how they work. You want to understand their context so that, again, you can sort of best understand how to get people to do the thing or to not disrupt other people from doing the thing. And what are the key factors that deter or help people do the thing? So then you can develop your strategies, right? If you know what those factors are, you can really actually support them to bring in a new technology into your lab or to bring in a new pathway, into your system.